So hello again, everyone. Welcome on this new session of the Thursday webinar organized by the ERN-EuroBloodNet. I'm very happy to welcome all of you on behalf of the whole network. As you know, the aim of these educational activities is to promote cutting-edge advances in rare hematological disease among health professionals. So today we are going to talk about sickle cell disease treatment revision with the Professor Mariane de Montalembert. She's specialized in pediatric statistics, option clinical research and transfusion. She's at the head of hemoglobin disease unit at the Necker Hospital in Paris, which follows 60 children at the Rosfed Healthcare Network for sickle cell disease children in the Parisian area. That is a therapeutic education unit for 700 children and family. She's member of the French Society of Pediatrics, in which she had chaired for more than 10 years the ethics committee of the French Society of Hematology, the European Network for Rare Congenital Anemia, the European Network in Rare Hematological Disease, the European Association of Hematology, and the American Society of Hematology. Finally, she's member of the EHA board since 2020. So please, Professor de Montalembert, the floor is to you. Thank you very much.
Thank you very much, Mariane. So it's a pleasure to be with you, even through a webinar and not face-to-face, to discuss the new drugs in sickle cell disease. And here you can see what I show often to explain the disease to the patients, the sickling process, which has been known for years and so far was not helping so much to increase life expectancy and the quality of life. And progressively, we had new insights on the pathophysiology of sickle cell disease. And we have learned that the red cell is not the only culprit in vasoocclusion and tissue hypoxia. The red cell is concerned with the release of free hemoglobin and free heme, with an increase in the production of reactive oxygen species. But also, vasoocclusion is related to the very strong links between red cells and neutrophils. And neutrophils are increased in number and activation, and they are linked to the wall of the activated endothelium, and notably via the selectin with the ligand of selectin connection. Platelets are also involved in vasoocclusion. There is an activation of coagulation system and an inflammatory status. We all know that hydroxyurea is the gold standard in the treatment of sickle cell disease, being used for 30 years now. Of course, it increases fetal hemoglobin production, but also it decreases the number and activation of neutrophils, and it reduces the imbalance in vascular tone. Having said that, it's not enough, because we all know patients who are taking hydroxyurea and still present painful crisis. And there is room for new drugs. These new drugs have been reviewed in a nice paper by Mariane Blood 2020. There are not so many data on the attempts to reduce the toxicity of free heme and free hemoglobin. There are promising insights, but not so many papers. And I will focus this presentation on the drugs for which we have a significant amount of publication. The first one is Voxelotor. Voxelotor stabilizes hemoglobin in a high oxygen affinity state, which delays hemoglobin S polymerization and delays cycling. A phase 3 randomized trial was published in 2019. Patients older than 12 years of age were enrolled. There were three groups, and the primary and a placebo, 900 and 1500 milligram per day. The primary endpoint was percentage of patients with increase of hemoglobin level more than 1 gram per deciliter at week 24. It was reached in half patients. 51% of patients had an increase of more than 1 gram per deciliter in their hemoglobin level, which was related to the point that they had less hemolysis, as demonstrated by a decrease in retics and indirect bilirubin. But there was no modification in the pain incidence. The FDA in the United States licensed the drug called X-Brita in patients older than 12 years of age having anemia. The indication for Voxelotor is anemia, low hemoglobin level. As we know the role of hemolysis and the toxicity of heme and of free heme, we can hypothesize that reducing hemolysis will decrease the severity of sickle cell disease. And we can hypothesize that it will have an incidence and decrease the rate of organ failure, especially vasculopathy. We can hope it will decrease vaso-occlusive crisis, but so far, we do not know. At the past EHA meeting, there was an abstract which was real-world experience of Voxelotor. 90 patients included, median age 30 years, median duration of treatment 10 months. Indeed, X-Brita, Voxelotor, has increased hemoglobin level by 2 grams per deciliter, which has really some importance, with a decrease in retics and with a decrease in bilirubin. In this trial, in a position which was published in the New England, patients having a combined treatment, hydroxyurea and Voxelotor, are more frequently an increase in hemoglobin level, which was not shown in the New England Journal of Medicine paper. Here, it seems to be an advantage of having a combined treatment. What about toxicity? There are not many data because in this abstract, there was no indication of the total number of adverse events. We just know that 4 patients had adverse events, diarrhea, rash, and fever that led to temporary dose modification. In children, the scheme of the study is rather complicated, and we know that we have 56 patients younger than 12 years of age having received the drug, with 47% of them having had an increase in hemoglobin level. And for children, we have more data about the tolerance because Jeremy Estep precised those data. It is interesting to observe that nearly half of the patients had side effects, but they were minor side effects, grade 1, grade 2. 10% had diarrhea, 10% had rash, 10% vomiting, and 10% abdominal pain. So it increases hemoglobin level with moderate side effects in half cases. In fact, we know that the risk of stroke is very tightly correlated to the severity of anemia. And given Voxelotor, we can hope reasonably that it can decrease the rate of occurrence of stroke. And this is undergoing investigation with a trial called HOPE-KIDS 2, which is a post-approval confirmatory study assessing whether the drug can decrease stroke risk using transcranial Doppler velocities in children 2 to 15 years of age. The second really main drug which is undergoing trials now are anti-Piselectin. Piselectin, this is a publication made by my colleague Slimane El-Ali in Hematologica. Here is my arrow. Piselectin is expressed on platelets and endothelial cells. I began this presentation by telling that we have a gang of cells involved in vasoocclusion. Of course, there are red cells, but also there are leukocytes. And leukocytes are closely related to activated endothelium thanks to the relationship between Piselectin and its ligand. And also there is a very close relationship between leukocyte and platelets. And secondarily, there is the participation of red cells. We knew for years that mice knockouted for Piselectin had less painful crises when they were submitted to stress. Patients. The drug is called Chrysolusimab. It is like Voxelotor, it is a preventive drug. It is given by intravenous way. The study is a phase 2 study on 1 year, during 1 year, which gave either a lower dosage or a placebo or higher dosage. The primary endpoint in this case was pain. It was not anemia, it was pain. And indeed, patients older than 16 years of age were enrolled, and the drug, Chrysolusimab, decreased the frequency of pain by 45%, which can be expressed as follows. More patients were painless, or there was a delay in the occurrence of a first painful crisis. Given those results, 2 years ago, the FDA approved the license of Adakveo to reduce the frequency of vaso-occlusive crises in adult and pediatric patients aged 16 years and older. Here, the indication is pain. But does it prevent organ failure, and especially cerebral vasculopathy? So far, we don't know. Europe was less generous and has given a conditional marketing authorization submitted to the observation of more efficacy and safety data. Novartis is developing the drug. Solace, phase 2 in adults, Solace, phase 2 in children, STAND, phase 3, and studies in some specific subpopulation, either experiencing priapism or with a moderate renal failure. Then what about not prevention, but cure? Here is an example of a pan-selectin inhibitor called ribipurcel. Here, the drug is not given in prevention, but at the very beginning of a painful crisis when the patient arrives to the hospital. They were promising data when the drug was called GMI 1070, and patients receiving when arriving at the hospital, the GMI 1070 had a decreased use of opioids. This led to a phase 3 study called RESET. RESET was stopped in August 2019 for lack of efficacy. But in fact, when you go back to the data, which has been shown at the past ASH meeting, the company has shown that when you give the drug very early, approximately in the first day after the onset of pain, it can decrease the need for opioids and the duration of hospital, and also in children, which is not so easy because, as we know, very often patients prefer to stay home when they experience the first symptoms of pain, and rarely they are arriving just after the beginning of pain. And therefore, I do not see, I must admit, very easily the room for and the indication for this drug. Then there are also new families of drugs. These new families of drugs, for instance, are activator of pyruvinate kinase, of erythrocyte pyruvate kinase. We know that red cell with hemoglobin S have an increase to 3-DPG, which decreases the affinity for oxygen, and they have a decreased production of ATP. These differences are decreased when using activator of pyruvate kinase. NIH there are two products as activator of pyruvate kinase. One is produced by Agios. The name is Itabupibat. It's given twice a day and given in adults. The NIH showed with an ascending dose study that, and the primary endpoints were safety and tolerability. It was shown that patients had an increase in hemoglobin level and a decrease in total bilirubin in hemolysis markers. Thanks to increase, we can hypothesize that it is related to the fact that the red cell is more robust and has an increased ATP production. Given these promising results, Agios has paved the way for a phase 2 study and a phase 3 study. There is another compound which is an activator of red cell pyruvate kinase, and the name is Itabupibat. It is made by another company called Forma. The advantage is that it is given only once a day. We have also positive results in the very preliminary phase of development, with increase in hemoglobin, decrease in retics, and decrease in hemolysis marker. And then we have this new drug called IMR6887, which is a phosphodiesterase 9 inhibitor, which increases cGMP, which increases fetal hemoglobin production. Some trials have been led in adults, and they show significant results with a decrease of vaso-occlusive crisis in the few adults who have been treated, and a phase 2 study is ongoing. Mariane Tellen has made a summary of the ongoing drugs trials. hydroxyurea is for sure the gold standard. It decreases anemia, it decreases pain, decreases acute chest syndrome rate, and most probably is effective in preventing strokes in given condition when the vasculopathy is not too severe, and it could decrease pulmonary hypertension. So we have a lot of data on hydroxyurea. In this presentation, I haven't developed L-glutamine because it was not accepted by Europe because of lack of efficacy data. Voxelotor, you can get, for instance, in France, we can have Voxelotor. It is a licensed, we can get it rather easily. It increases hemoglobin level. We have no data to think it decreases pain. And there are ongoing studies to observe the effects on chronic organ damages. Chrysolusimab is Adagvil is also undergoing many trials. We know it decreases pain, and we are waiting for data about chronic organ damages. This is my last slide. My last slide is about the cost of the drugs. For hydroxyurea, I've chosen the formula called Cyclos, which is more expensive than Hydrea, which is as equivalent, it is hydroxyurea. And Cyclos for one adult is about 600 euros or dollars a year. These costs, I found them when going to internet, and they are submitted to discussions between the companies and the national health authorities. And for instance, I saw for Voxelotor, $100,000 a year. And for Chrysolusimab, it was $100,000 a year, and the company has reduced the cost by half, and now I've been told that in France it should be 50,000 euros a year. Finally, bone marrow transplant, 300,000 euros seems rather to be cheap, but you need to have a donor, and you have to accept the toxicity related to myeloablation. Here is the problem with the cost of gene therapy. We had a discussion between Bluebird Bio and Europe. Bluebird Bio, gene addition, asks for 1,800,000 euros for one gene therapy. The European governments have refused, and Bluebird Bio has decided to leave Europe, and the development of gene addition related to Bluebird Bio for the moment is stopped. And I think that all these points have to be discussed on an ethical, scientific, and discussion with the governments and the patients. And so far, I think it was my last slide, and I'm of course open for all the questions. And I thank you for your attention.
Thank you very much, Professor de Montalembert, for this clear and exhaustive presentation. And so I encourage the audience for asking questions. So you can ask both ways. You can write in the chat, or you can raise your hand so I can unmute you if you prefer to formulate the question orally. Okay, I see there is one hand raised. Professor Benitez, you can activate your audio.
Okay, thanks, Mariane.
Thank you.
Thank you for the presentations. It's important to see the price of the drugs. It is very important. But probably in the past we have another drugs with this type of considerations. We need to add the others the other results of the treatment, because with the results of Chrysolusimab, with a reduction of 50% of the box, maybe Chrysolusimab is more expensive, but the results on hospitalization and all the drugs that they need in the outcomes, maybe it's important to see the price of the drugs, but we need to consider other benefits of the drugs. I don't know what is your opinion about this?
Well, it's not easy because, in fact, for instance, in France, the government has decided that there was not enough proof of efficacy and is waiting for more proofs. So I think that I am quite confident in the possibility of Chrysolusimab to reduce pain, but I think it will take some time, indeed. And so far, in my country at least, I think we are in a difficult condition for at least some months before we get the results of the ongoing trials. Most probably when we will have the results of SOLACE in children, of STAND in children, and in adults, of all the trials, perhaps I hope you're right, and I hope we will have more arguments to say to the countries, yes, you need to reimburse the drug. So I have a question. When do you think Chrysolusimab would be available in other countries in Europe? It is the same questions. In fact, it will be, I think, for instance, SOLACE will be closed for, I think that in 2-3 years, all the trials will be closed and it will be more available. But I do not see Sickle Cell Ireland. I think you can ask to Novartis and you can ask them to have some compassionate authorization, because really it works, and we have the feeling it works quite efficiently. So I think that country by country, you have to ask to Novartis company to have a country by country agreement. This is what I think. I have a question, Mariangela. The indication about for bone marrow transplant, and I will try to ask this difficult, excellent and difficult question. Excellent and difficult. So it depends on the country where you are living in Europe. For instance, if you are living in Germany, once you have settled the diagnosis of sickle cell disease, I think that most patients are automatically offered bone marrow transplantation, or at least the family is offered to make HLI typing. This is a position. In the UK and in Belgium and in France, I know the problem, and I know that there is no systematic HLI typing for each child. And it is thought that the benefit-risk ratio must objective the superiority of bone marrow transplant. What are the risks of bone marrow transplant? The risk so far, and it's a 3 to 5% risk, vital risk. I had 2 years ago a child who died from bone marrow transplant. And so the risk of vital risk, a risk of death, which is between 5 or 3%. Then there are the risks for GVH, which are about 10%. And then there are the risks for fertility. Of course, we offer techniques for cryopreservation. For women, when we make ovarian cryopreservation, we know that there is a possibility, I should say, of about 20-25% of getting pregnant after the reinsertion of the ovarian tissue. For men, we do not know at all whether the fertility cryopreservation techniques we are using will be useful. So in my experience, I do not systematically propose bone marrow transplant to everyone. But I think that there are very good indications and that they are increasing, and that ideally bone marrow transplant should be proposed not too late because the results are better. If it is a good answer to Laura Ruth, no, it was not, it was Soterula. So this is how I see the indication. To the question, is it a possibility of Bluebird Bio coming back to Europe? I don't know. I don't know, because it was a very brutal decision taken very recently. I think there is not only Bluebird Bio. Bluebird Bio is gene addition. But if you consider gene editing, which is, for instance, performed by Vertex company, I think that Vertex company has understood the message and will not ask for around 2 million of euros of dollars to have a gene therapy. So I think that they are going to think about it at one step. First, Vertex will develop something cheaper, and then I think Bluebird Bio will decrease the cost. But honestly, these are simple hypotheses. I do not know. So I have a question about Rivipancel. I don't know. The question is, it's in French. Given there is no indication for Rivipancel in hospitalization, could we implement a study to offer to patients to have Rivipancel at home? It is David asking the question. David, it's not possible because it's not possible to implement a clinical trial with a home. When you try a new drug or finally a rather new drug, you cannot begin with home treatment. So perhaps one day, but it was a question raised by Chrysolusimab, because during the COVID-19 infection, they said, well, people are totally afraid of coming to the hospital, and would you agree to make a Chrysolusimab injection at home? And all the expert committee, I am within the expert committee, we totally disagreed, and we said, no, we cannot try a new drug at home, because whenever there is an adverse event, it won't be possible, it will not be possible to manage it efficiently. So home trials so far are not possible. Yeah, David, you made a translation in English. So sorry. Okay, thank you for the nice, okay. I have got a, other question. Can you indicate? So Chrysolusimab, it's pain. Voxelotor, it's anemia. These are the data we have this evening. It's not a good idea to treat a painful patient with Voxelotor because there are no data of efficacy. It's not a good idea to treat a painful patient. Sorry, it's not a good indication to treat an anemic patient with Chrysolusimab because there are no data on hemoglobin. Chrysolusimab is pain, Voxelotor is anemia. Voilà. 3 more messages. No, I haven't any more messages. I'm looking back. One new. Okay. So far, I hope I have answered the questions, but I'm waiting for other ones if you wish.
Yes, there is one.
Yes, Chrysolusimab, no, it's okay. Sickle Cell Ireland. I'm dreaming about Ireland. So no, I dream to go, but Corina, she knows that I'm dreaming to go to Ireland. Bon. So far, it's not, because Chrysolusimab is given in trials, and there is, so far, it is an exclusion criteria. If you are undergoing monthly transfusion, you cannot be enrolled in a Chrysolusimab trial. So today, the answer, can Chrysolusimab be used in parallel with transfusion therapy, is no, it can't be. Vous pouvez pas, je suis en réunion, lui demander ce qu'elle... Sorry, ce qu'elle veut. Merci, Alizé. So I think that perhaps once it will be possible, but so far it's not possible. It's an inclusion criteria. Alors, what role can patient organization play in pushing for the lot? I think that it is very important, this question, because in France, and I think in several countries in Europe, we are blocked because Chrysolusimab is so expensive that governments refuse. And I think that patients association, they have a big role to play. Really, because it is really an effective drug. I haven't seen any side effects, so I think it's a pity not to have it more easily available. And I do think that there is a role for patients association to push for its reimbursement, really. And I would say yes. There must be, I think, patients' lobby on the reimbursement. So, do you think we should make BMT more available, including MUD? Hello, Corina. Yes, I think in one hand, we should make BMT more available. Yes, I think that there are not enough bone marrow transplants, but you have to be clear. You have to say, well, we are all impressed by the stories we have lived or experienced. 2 years ago, we had one death of infectious complication in a patient who had never experienced a painful crisis. She had abnormal transcranial Doppler. And for the parents, it was not believable that child is dead and she had never had any pain. And transcranial Doppler abnormality, doctors realized that there was a risk, but not the parents. So I think that there is a risk of dying, and you cannot not tell it to the parents. And I have colleagues and friends who say, oh, there is no more death. That's not true. You have, according to the series, 2%, 3%, 5% risk of dying. So it has to be told. Then, when I will leave you, I have an appointment with parents of a child. He is experiencing hepatic GVH. It's not easy to go through because he has hepatic GVH for 6 months. And there are complications, and they do exist, those complications. And you cannot tell there are no complications. And then there are also fertility issues, and you cannot say there are no fertility issues. But once you have said everything, and once the child is willing to undergo this process, because the parents are always willing, the child is another issue. If the child wants to have bone marrow transplant, yes, I think you have to increase the indication. And we are increasing our indication really very, but we have pluriprofessional discussions, and it's not a one physician's initiative. It is discussed in a consortium of physicians, and when we discuss with the families, and that's it. But the results, so intrafamilial, but Corina, the results with MUD are not so good. And except some cases in my life where the patient, he was dying, he had so many complications, I went to use a MUD. In other cases, really, I would not recommend MUD transplantation. And haploidentical, they are progressing, but so far we do not use in children in my unit haploidentical. But I think perhaps it will be the future. But I think the death rate, I would not say mistakes, but it is around 8%, I think, something like that, of death related to haploidentical. It's not nothing. It's high. David, given the povascular access is one of the drugs not in intravenous. Yes, David, Chrysolusimab is intravenous, and you may have venous problems. And some patients, they need to have a venous device to have a portacat because it may be a painful injection. So it is an issue. And then, yes, Voxelotor, it is oral, but it does not work so far on pain. We will see. Agios, Itabupibat, and Itabupibat, it is oral. We are really at a very fascinating period because a lot of drugs are undergoing development and we do not know. Okay, Corinna, thank you. So, Laura, Ruth, you're in an association of patients in Ireland, that's the point? Yes.
Yes,
Yes.
and not only Laura also is an European association. So she's a very expert and dedicated patient advocate. I answer for you, Laura, sorry.
If you want, I don't know, but here there are data. In 1 month, there will be the new ASH meeting, which is a sort of a big thing with all the results from all the trials are presented. So perhaps the data I have shown, for instance, I have shown results from the past ASH meeting in December 2020. Perhaps there will be new things in after this ASH meeting in December. So we can make, I don't know, in March or April, a new revision and with the new findings, because I think that new findings will be, or new drugs, I don't know, will be presented. So it was, finally, it was the point at 2021, but perhaps 2022, there will be new development and a new, it will be more informative. I think so.
Thanks so much for the audience and for Mariane de Montalembert. It has been such an inspiring session. Thank you very much. Have a nice afternoon.
It was my pleasure. Bye-bye.
Bye.